All right, so let's talk about crucial conversations with the impaired provider. We'll expand that a little bit beyond just physicians and whoever we're working with, and what our obligations are and what the implications are. I think this is an exciting and timely topic, and through the course of my career and in the administrative and leadership roles that I've had I would like to say the pleasure of dealing with many of these, not because I want anyone to be in this situation, but because I've never regretted intervening. And I've always been thanked, ultimately, at some point along the way. Not right away, but at some point, I really needed this, I'm glad you did this, I'm on the right path now. Never have I ever regretted pulling somebody off a schedule or intervening on their behalf or the patient's behalf. And I find now more than ever, this is happening more often. Are you finding that you're getting these complaints, or the awareness of this is getting more so than it ever has been, or no? Okay, and some of you are just really ready to go to the bar at this point. I don't know. That's later. And so, I think we really need to focus on this. And as Sherry mentioned, I find that a lot of individuals really don't know what to do. When they've identified it, or they think they've identified it, they're not really ready to pull the trigger because they think they could even be at risk. Well, what if I do this and I'm wrong? If I do this and I'm wrong, what kind of retribution will occur toward me, either from the individual, from the institution, from a legal authority, whatever it is? And I will tell you every document I have read, whether that be a study on this topic, whether that be a regulatory document, I'm providing regulatory guidance, whether it be from the AMA or the Federation of State Medical Boards, this may help you. Everything is focused on patient safety. The underpinning of these policies and these recommendations are about patient safety. So if you act on behalf of the patient's best interest on some information that you have, you're fine. You should be protected because you have to protect the patient. And it's one thing not to know of an incident, a concern, or an issue and not do anything about it. You can't really react to something you don't know about, right? You'd be clairvoyant if you could. But what I run into concerns with or problems with is when someone is notified, especially when they're in a position to do something about it, somebody in a position of authority, a nurse manager, a hospital leader, a physician, doesn't even have to be a medical director, you are now culpable. You knew about it, you didn't do anything about it, and now there's been a bad outcome with a patient or whatever, and you should have intervened, you should have acted. So especially once you are notified of any suspicion, you have to intervene. And I'll tell you a couple components that I think are critical at any time that you run into these situations. And then I want to discuss some of the data and some of the background information with you quickly. So I'll give you a good example. I won't give you all the details because I don't want to share every individual detail with you, but just to illustrate this concept. I had a recent conversation with a doc who was concerned that there might be an issue with one of the providers. And the first step was pulling that person off the schedule, which was absolutely the right first step. Perfect. Because you have to protect the patient. You have to sort this out and then see if they're fit for duty, because patient's safety is hanging in the balance. So you have to do that. But what was supposed to happen after that was unclear. And I think what we need to do at all of our facilities and in every healthcare institution in the United States and in your group and in your department is have a policy that outlines what you're going to do. You want to be protected? Well, you are protected by doing this, but if you have a policy that says when you are notified or you believe you have a credible concern about patient safety from impairment, then you must pull somebody off the schedule. You're just following your policy. What you don't want to do is do a one-off every time you hear about this, and then you act inconsistently from one event to the next. Now you could get yourself into trouble. Why did you act this way with this provider, but then 6 months later you acted differently? That will get you into trouble. So have a policy that says when you are notified or when the information comes to you or whatever it is, you are going to take these actions. The first one is pulling them off the schedule. The next is certainly letting them know that what the issue and concern is and that you're here to support them, and you're going to need some sort of a drug test. They're going to need to submit to that. And what I've seen happen too is at some institutions, when you don't have this well planned out and you don't have this designed ahead of time where you can just flip the switch to help the impaired provider, it's like, well, where can I get a drug screen? Well, we already talked about CVS. I mean, hey, maybe retail clinics, you can get them there. Of course, I'm kidding, but you can't use your hospital routine lab analysis. It has no chain of custody. Okay, so you can't do that. You have to have it set up in advance so that when you get that drug screen, that's handled properly, and the results are reported in a way that cannot be tampered with. And you can't do that on the fly. You know, one that I dealt with recently was interesting. I gave that recommendation to, you need to make sure that you do this part of it. It came back later and told me, hey, you know what? You might be a little bit outdated on your recommendation, because they came and got a hair sample from the provider. They did a hair sample. There was no drop in urine. That just makes it cleaner anyway, doesn't it? Just a lock of your hair as opposed to drops of urine. And let's make sure that urine is not at room temperature. Let's make sure it's body temperature. It's amazing the stuff you have to go through to make sure that this stuff is actually accurate. So you've got that sample, and you send that off, and then they need to have a mental health evaluation. We need to know, are they dependent? Did they just have an issue with substance abuse or inappropriate decision making, or are they dependent? Do they have dual diagnosis? Are they at risk for suicide? You need to intervene to help them as well as helping the patients. It's very, very important. So you should have, in my opinion, a relationship with a mental health professional in your community, so that when you call them and say, hey, listen, I've got another one, that would be a problem, but I have someone I'd like to send to you. Remember, we talked about this 6 months ago, and I need that standard mental health evaluation, and this is their name. They're going to be contacting you for the appointment, or here's their contact information. You can contact them. They're off the schedule. Here's what we're going to do. Then you know that you trust that person. You like the work that they do. If you didn't like the work that they had done for you in the past, you would find someone else to do it. And here is the final piece. The provider in question has got to agree to this. Can they say, you're not taking my hair or my urine? Yeah, they can say that. And then you can also say, you have put me into a box canyon here. You've put me right in a corner. I cannot help you if you don't help me to help you. Help me to help you. You have to tell them that, because if they don't agree to the program and the plan, that might result in their termination. Just like when they go to the mental health professional, because of HIPAA and for other privacy concerns, they would have to sign a release that says, so when we're done with this, you authorize me to talk to your medical director about this. Are you okay with that before the evaluation even occurs? If they're like, no, I'm not doing that, listen, this is your pathway back. It might be quick, it might be a couple of days or a week. If we find that you have a mental health issue or dependence or both dual diagnosis, then we may have a longer pathway to help you to come back into practice. But this is the construct of what I think every department needs, that isn't necessarily clearly outlined in the literature or clearly outlined with regulatory bodies. But from a practical standpoint, I want to share that with you, because I think you can make a tremendous difference, not just for patients, but in the individual lives of providers. What is also on the rise and is very scary is suicide with providers. When you look at the general population, physician suicides specifically are much greater than that with the general population. So for males, 40% greater than the general population. For females, and I was surprised when I read this about 6 months ago, 130% greater than the general population. And certainly the triggers for this can be an adverse outcome with a patient, professional liability claim or medical malpractice, or certainly these types of things, impairment, et cetera, can come into play as well. And can go the other way too. When this happens, it can create substance abuse and dependence, which can then make you more likely to commit suicide, or attempt it or successfully commit it. So we have to be aware of this, and we have to understand how significant a mental health crisis this really is in medicine in general, and we have to be aware of it. And you are protected. Don't worry. Don't be concerned about doing the right thing for people. You'll always be okay. You really will. All right, so let's talk a little bit about some examples. So some may think, this can't happen. These are learned doctors, people who went to medical school and residency training, and we respect them as colleagues. That's all true, but they're people first, and people can fall victim of substance abuse and dependence. Here's a good example in the San Diego area. Won't go into great detail, but this is all searchable on the internet, and this was alcohol and oxycodone of an emergency physician. Not an uncommon tale, which is unfortunate. Here's another one, alcohol. And alcohol is the #1 drug of choice with impairment and dependence among most healthcare providers. Probably a lot of other people too. But let's talk about it. Don't take any chances. Has anyone here ever had a glass of wine? Now you were so freaked out by my initial comments, you're like, no, don't touch it. Never. It's okay to drink. It's okay to drink and have fun. It's not okay to drink and drive. It's not okay to drink and take care of patients. So don't take chances. Where this becomes a problem for our providers is when this departs from a mental health problem and becomes a criminal problem. It's bad enough when it's a mental health issue. But when it becomes a criminal problem, it's unforgiving and it's unforgivable. So don't take chances even yourself. You know what? I'm pretty good. I've only got 5 miles to go to get home. You know what? There's UberX these days, which is so cheap. You don't even have to get the black car. You can get just somebody's regular car that's cleaned up pretty well with a bottle of water in the back. You know, come on. I like UberX, not for this purpose, but, you know, listen, I'm thinking about selling my car and just taking UberX everywhere. I meet a lot of nice people, except the guy, there was a bad case, wasn't there recently? What city was that in? Yeah, who would have guessed it? All right, so scratch the UberX thing I mentioned. Okay, forget that. So maybe not in Michigan necessarily, but anyway. But what I'm saying is if you take a chance and you put your license at risk and your professional career at risk for a bad decision, it's just not worth it. The holiday party, I find that this happens. So you decide to go to a holiday party, you or your providers, whoever it is, and you're going to let your hair down with the staff. You know, unfortunately, you are still in a position of authority. The physicians in your department are still authority figures as well. This isn't the time to really let your hair down. It might be a time to have a couple, relax a little bit, be social with people. This is not when you're swinging a lasso up on the stage and no, that's not. And if that ever happens, okay, that's up to you. I would do it 7 zip codes away from where you live. But nonetheless, if you want to get crazy, but not at the holiday party. Because people will then, this is a work-related function, and they will equate that behavior with work. And what happens the next day? So it could either be after the holiday party or just going out on Friday night. And I found this to be something that's been reported to me on more than one occasion, and I don't think it's a dependence issue, but it raises red flags. So if you are out on the town, and it's Friday night, and you don't get back until 2 o'clock in the morning, and you had UberX or whatever you did, and you were responsible, but you had a few, and then you wake up at 6 a.m., you're going to work your 7 a.m. shift. What is your alcohol level? Is it 0? What's the legal level that you can have to practice medicine? Is it 0.08? No, that's to drive a vehicle, and it's silly. You can't have alcohol in your system and take care of patients. So what's interesting about that, I don't think some people realize that, I need to decide when it's a safe time to stop or not work the next day or not drink, 12, 15, 24 hours before I'm going to work shift. You can get yourself into real trouble, and it can impair you from a cognitive standpoint. So dependence equals mental illness and disability. That's what we have to remember. This is a mental illness, but a DUI is a criminal offense. You made a bad decision there. It might be related to your mental illness and substance abuse and dependence, but now you have criminal charges against you, and this gets a little bit different. Now, through the American Disabilities Act, we have certain things that we must do for people with mental illness and take care of them, and we'll help them. But if it's a DUI only, you can't really help people very much with that. It's a challenge. Here's another example. How many of you like your physicians to be punctual? Okay, come on, this is not, there are no trick questions here. Okay, so at least 4 of you think punctuality is a good trait in your physicians. All right, okay. How many of you have seen a physician come in and they feel so sick, they get themselves treated? They're getting IV fluids in the department. They're not going to call in sick for their shift. Has that ever happened? Do you admire that? It's a little crazy, but I kind of admire that too. And I tell you, I've worked sick. I've never gotten IV fluids. I'm afraid of needles. But I wouldn't get the IV fluids, but I've worked feeling pretty bad sometimes. All right, so Dr. RT is an emergency physician and a good example of being punctual and not missing a shift no matter what. February 2010, there's a DUI and the alcohol level is 0.12. Can you operate a vehicle? No, you cannot. Okay, 2 hours later arrived for her night shift. You can either say, wow, that is a great work ethic, or that is horrible, horrible judgment. And maybe a combination of both, mostly horrible judgment. And this is going to be a pattern. November 2010 DUI, now 3 years of probation. So it is amazing sometimes how much deference and latitude medical providers and particularly physicians will be given because of their education and what they do in the community. But it doesn't last forever. At some point, they're just going to say, no, we're not going to tolerate it. Here's another good example. Dr. Raymond Cook. This guy's a plastic surgeon. September 11, 2009, he got a DUI. He was driving 90 in a 45. 90 in a 45. And I do believe that from the sources on the internet, he did have, I don't know how much he was drinking that day, but he did have a previous dependence problem. Okay? So he struck another car. Here's that car. Yeah, pretty bad situation. Here is the 20-year-old ballerina that died in that car. And I won't leave that image up very long, but it's really, really sad. But he was sentenced to 36 to 53 months in prison and surrender his medical license. He can never practice medicine again. And he killed somebody. I don't know how you can ever live with that. 90 to 45 intoxicated, and that is unforgivable. It really is. So these things do happen, and your intervention can help avoid them. And so it's very, very important for all of us. So now let's look at some of the information in the background that will protect you and give you the foundation you need so that you can intervene appropriately. Let's look at what the AMA says. The AMA says in their Policy Finder database, and you can search this yourself if you like, substance abuse among physicians has defined impairment as any physical, mental, or behavioral disorder that interferes with the ability to engage safely in professional activities. Well, let's pause there for a second. When I threw up the first slide and when Sherry talked about the impaired clinician, didn't you think we were just going to talk about drugs and alcohol for 30 minutes? Anybody? Yes. Yeah, a few of you. Well, you know what? They don't make any distinction, not the AMA. They define the categories, but they don't draw any broad distinction about your reporting obligations, either from the AMA or the Federation of State Medical Board, or even necessarily with your state medical boards when someone is cognitively impaired. I'm sure that we all know people that we've worked with at some point that they just aren't acting right. They just aren't working as well as they should have. You know, I can give you a good example of a man that I knew through professional circles but never worked with him. He was a phenomenal guy. And I heard from his partners that it was getting more difficult for him to remember things, and he was putting Post-its all over the computer and the EMR, so finally it was like completely covered up with Post-its. He had early and very aggressive Alzheimer's. He was dead within about 5 years. But he couldn't function, but he was trying to compensate. We need to intervene if somebody is cognitively impaired. I have heard of individuals trying to perform a procedure, and they can't see to, let's say, complete the procedure or to thread a J-wire or something along those lines. Well, just because the brain's working okay, but the eye to the brain connection is not, it doesn't give you a pass. It's a patient safety issue. You might have to make accommodations for them, put them in a different work area, have somebody cover them to do a procedure that they can't see well enough to do, help them with vision, but it's the same scenario. If patients are at risk, you have to pull them from the schedule or make those accommodations while you're sorting it out so no one's at risk, and then figure out how to help them. Same thing. So the Federation of State Medical Boards, they define impairment as the inability of a licensee to practice medicine with reasonable skill and safety as a result of any of those things, and we've listed all of them. And it can even be, again, if you look at B, a physical illness or condition. Maybe it's unsafe for you to practice, not because you're not thinking clearly, not because you are impaired from substance abuse or dependence, but because you just can't function physically in a way that is safe for patients. That's possible. We are responsible for recognizing these limitations. All right, so the incidence, and these numbers kind of go all over the place. What I'm finding in the current literature is that physicians have about a 10 to 12% lifetime prevalence of impairment from substance abuse or dependence. And that's the same as the general population. And they say the stressors are a little bit different in definition, but overall are about the same. People who are having work stress, doesn't matter what type of work they do, those people are at risk. People who've had loss in their lives, those type of things. Same type of thing, but we're in a very stressful environment. That's why I think these numbers are going to change. I think these numbers are going to go up for physicians, just like the suicide rate has gone up for physicians. Maybe we just don't have the current data that we need. And this was data from 2009. This other citation said nurses up to 20%. I think that's really in the same range. So anywhere between 10 and 20% is going to be our rate. That means if you've been doing this for a couple of years and you've had people in your hospital, not necessarily just your department, there's somebody there who has a problem, and hopefully we can help to intervene. So how do we identify them? That's one thing too. If you're in the department, if somebody comes and tells you, listen, I think I smell alcohol in Dr. So-and-so's breath. I had that one time, and Doc said, listen, I just used mouthwash. I'm like, I know, and you were minty fresh, and I'm totally into that. But I got to pull you off the schedule because one of the nurses reported that they think you have alcohol in your breath. I'm not judging you. I just can't let you work until we sort it out. So how do you identify them? If you are there yourself, what's a way to help sort this out? And this particular article, I think, is really helpful in outlining this. And if you need it, I can certainly get it to you. Signs and symptoms of addiction, but let's look at specifically with alcohol. And they talk about some of the subtle findings. Maybe you're sweating, you're irritable, you isolate yourself. That could be just normal day for some of our people, right? Sweaty, irritable, and isolated. I think that person's in this room somewhere. That doesn't mean that you're abusing alcohol. But I love some of these very subtle findings. So let's take a look at these. Alcohol on your breath. You can't overlook that one. How about slurred speech? Well, you should pick up on that. Ataxia. So you're ataxic. Hey, you were going to room 7, you ended up in room 9. What happened with your navigation system? That's a problem. What about, I love this one, hidden bottles. Okay, who hid the Jack Daniels at the nurse's station? I need to know. No judgments here either. It's amazing. So hidden bottles, and I really, I love this one too. This is amazing. Frequent hangovers. If you're hungover and you look at somebody they're hungover, they got a Bloody Mary with, with celery in there, and they're like, it was a rough night, and I'm going to get to the patients in a minute. If they're hungover on the job, don't overlook that. That should be one that you shouldn't overlook. And what about with opioids, taking other types of drugs? And you can see many different things as well. Some of them are very subtle. I love this one. Volunteering to return waste drugs at the pharmacy. Hey, listen, I was going that way anyway. Just save them up at the end of the shift. I'll be happy to walk them down. Let me go back here a second. I love this one. Rummaging through the sharps container. Swear I dropped my keys in there. My keys are in there. Wow. But this is the kind of behavior. If you see this, it's like, that's aberrant behavior. I know it when I see it. That's aberrant behavior. And I think we probably need to pull you off the schedule. And if we find your keys in there, that'll be the first phase of this investigation and evaluation. If your keys, in fact, are in the sharps container, we're going to ask why. And we're going to pull you off the schedule again. How would they get in there? So that gives you some really good advice about who you can identify as maybe having an issue. So further information about identification. So this article, and they vary, but this will give you a good sense of demographics. So they looked at a small number of people. So they had an N of 52 who were physicians who were impaired. So the age was 53. The mean age was 53. So you're looking at middle-aged, depending on how long your life is going to be. If you want to live to 120, great. Middle age isn't until you're 60, so you can just discount that statement. All right, males, 94.5%. So for this particular study, small numbers, but it helps us. We're talking about middle-aged males, and 71% were white, and other ethnicities dropped off from there. So that just gives you a sense of who might be at greatest risk. They don't have to follow this demographic, but it may give you a sense of who you should be looking toward. So the medical specialties, they listed anesthesia is number one on the list here, but then when you combine family and general medicine, 21%, internal medicine or one of their subspecialties, 16%. And this data really is all across the board. If you look at this additional article, they say anesthesia, number 1, emergency medicine, number 2, and I think it's largely because of access. I've read other articles that say, psychiatry has a huge burden with mental illness as well, not just taking care of it, but owning it and having it, and also with substance abuse and dependence. They do. And I don't blame them. I tell you what, if I could not be a mental health professional, what we deal with in the ED is enough, and I'm glad we can help those people, but I tell you what, if that's what 9 to 5 was, 5 days a week, I know, let me just say I know why they're up on the list. I really, really do. Anesthesia, a lot of people say it's because of access. Well, you've got to have the need and the reason, but then when access is there, it's really, it's the perfect storm. It brings me back to, I'll give you a quick story. I don't want to spend a lot of time, unless you don't want to hear it. Do you want to hear a story? Okay, when I was training, there was a guy I trained with. He was a general surgery resident, and I liked him. He was a cool guy. I won't mention his name, but it didn't go well. It was in a tiered surgery program, so he was weeded out in like the first 3 or 4 months because I knew at the end of the year about a third or half of them would be gone. Well, he was weeded out early on, and he talked about coming to emergency medicine. There wasn't a spot for him there, certainly wasn't up to me. I was a resident. He wasn't going to go into emergency medicine. He goes into anesthesia. He'd had a divorce. He had 2 kids. And this speaks to the concept of access. I don't know if he really had substance abuse or dependence issues. He might have, but he certainly had mental illness. Christmas Day of that second year, the hospital gets a phone call that his apartment had the yellow tape across it, that he'd gotten some yellow tape, and he put a note on the door. It said, "Call the police, do not come in." And there were Christmas gifts for his 2 kids on his kitchen table, and he was laying in his bed with 2 IVs started by him, and he had used pancuronium and thiopental. In that order, because he knew that the Pavulon was going to take a while. And so then once he got that on board, then he went ahead and did the thiopental, and he's laying there with the syringes right there. I mean, that's mental illness. There might have been some substance issue there, but he certainly had access. I think access has been controlled a bit more now. You've got to get into a Pyxis or a Diebold system or something else. When they looked back at that case in a root cause analysis, they saw him getting everything ready the night before. He was asked what he was doing. He said, "Oh, I just want to be here early and pre-op for the cases in the morning." He was pre-oping for one case. And it's a sad situation. But again, I bring this example to you because it has never left my mind. I don't really think there was much I could have done, but if there's anything we can do to intervene, recognizing that somebody is struggling, we can really save a life. We really can. All right, so if you look at the Federation of State Medical Board policy on physician impairment, here's some of the reporting requirements. You can read through this at your leisure. In the interest of time, I'll just hit the first topic. In cases where an intervention uncovers one or more of the following, a physician should be referred for professional evaluation or assessment. And it's the things we talked about. If you already know they have a substance dependence history, they should be in a monitoring program. So that needs to potentially be reported. If they have a substance abuse problem and now it's out of control again, that needs to be reported. If you just suspect it, then that needs to be dealt with. But those are the different areas that they give you to give you guidance to make sure that you're intervening when you should. All right, and the big one there basically is when you can also have behavioral issues that aren't related to substance, but also that's the one we'll see most often. I wanted to emphasize to you here that when someone comes to you with a complaint or report that this might be a new issue, not one that's pre-existing, that's going to be harder for you to flip the switch on this process, but that's when they need you the most because they've never been evaluated or assisted in the past. All right, so the AMA regarding reporting requirements. Physicians have an obligation to report impaired, incompetent, and unethical colleagues. We'll leave the unethical colleagues out of this discussion. But I would say the incompetent or impaired, no matter what the reason, no matter what the genesis or the etiology is, if patient safety is at risk, you have an obligation to report. And what do state medical boards say? They say a lot of different things. You need to know what your state medical board says. I know, for instance, I looked at Ohio recently, and Ohio says you must, once you identify it, you must report this to the state medical board. There's an exemption. I think if you've already entered that person into a treatment program, et cetera, and it's been dealt with, I think that you're exempted, but if not, and you'd have to check the language yourself, but they say many different things, but many states require that you report to the state medical board. And you have to know what your obligations are so you don't get yourself into trouble. So what are the barriers to reporting? We won't spend a lot of time here, but this particular article in JAMA really focuses on this. Sherry hit a couple of these too. I mean, some people in the top response is that, well, you know, I thought somebody else was already dealing with this. Or I didn't think anybody would do anything with it. What about retribution toward me? What if they look at me next? These are all reasons why people say, I'm just going to look the other way. We have an obligation to our patients and our colleagues, and we can't let this go unnoticed if we recognize it. Very important. This flowchart, I think, is helpful also to give you a sense of what you might want to set up in your department. So if you identify there's a problem, you can go through this whole flowchart of actions and interventions, assessing, and if you find nothing, you observe. If you find something, you move to the next stage. The only thing I disagree with is a glaring omission in this document that I would ask you to include. Is at the very top it says nothing about removing that person from patient contact. That's got to be at the very beginning. Then you do your investigation. They talk about doing a discrete evaluation. Well, I think that's a bunch of BS. If you're going to do a discrete evaluation so nobody knows that you're trying to protect the provider, and I get that, we should do that as much as we can, but not at the expense of patients. So protect them as much as you can, meaning the provider. Be as quiet and discreet as you can, but they got to come off the schedule. That's the only change I would make here. And you can review that if you'd like, and that's available in the syllabus also. All right, so how are addicted physicians treated, and what are treatment programs about? It's a national survey, so physician health programs. These are not like HMOs for physicians. They're not. These are for impaired providers, okay? This is what they're for. A survey of 49 state PHPs, 86% responded, so this is a pretty good sample. This is an important take-home message. These programs are not there to provide treatment for substance abuse. They'll let you know what you have to do. They'll give you the resources of what the next steps might be and what your obligations are. They are there for early detection, assessment, and evaluation. What they recommend is abstinence-oriented residential treatment, 60 to 90 days, and that's different than the general population. What they're saying is that person should be inpatient somewhere in a facility for 60 to 90 days, and then a 12-step outpatient program after that, random scheduled urine monitoring. I've always wondered that's scheduled. As long as the provider doesn't know the schedule, then we're cool. If they know the schedule, well, then it's worthless. Status reports have to go out to licensing boards, employers, and insurers. That all has to be in their employment contract. So when they're going to come back to work, these things we will require, or you can't come back to work. You need to sign this addendum or a new contract. This needs to go on for 5 years. By most people's monitoring programs, 5 years. And what's interesting, based on this survey, 22% had a positive test somewhere along the way in the 5 years, but 71% were still licensed and employed. That's great. That is better than the general population. A lot of people relapse. We see them a lot. And no, providers do pretty well when we intervene. And this 2-year longitudinal outcome study on addicted healthcare professionals really helped as well. Univariate factors predictive of relapse in this sample were female gender, alcohol is the drug of choice. I mentioned that is oftentimes the number one. And interesting, higher scores on personality inventories consistent with antisocial personality. Could you imagine that? So are you doing personality inventories before you hire someone? Well, I think we need to start. I could just imagine this. You know, we haven't hired anyone with an antisocial personality disorder in quite a while. I think we need to hire this one. That just spice things up, particularly at the holiday party. So that doesn't really make a whole lot of sense to me. But so good information there from that article. This is another one speaking about risk factors for relapse. Drug of choice, if they're still using that drug of choice, they're going to relapse. So 85%. When do they relapse? 58% between 0 and 1 months. And usually, oftentimes in the general population, especially with alcohol, that's going to be in the first month. That's when it's going to happen. How do we get reported? Well, chemical monitoring, workplace monitoring, and then number 3 is going to be the person actually reports it themselves. You have to create that climate and that culture and that environment and relationship to say, hey, if something happens, I get it. We're working through this problem. It's a demon. Let me help you with it. I want to be your first phone call if that's what's going to happen. And what are the drugs out there? Fentanyl, the odds ratio of relapse is 1.7 if that's your drug of choice. Other majors are going to be Demerol and morphine based on this particular article, and it's about 2.6 the odds ratio, 2.6 times more likely you'll relapse if you're abusing one of those. And then the minor opioids, 1.38, and that's codeine, oxycodone, and hydrocodone, and even tramadol, which people don't really realize is a weak opioid, and it has addictive potential. So just to give you a sense of who's at risk for relapse when they're back in your department, this article from JAMA, also from 2005, stands today. The most important piece of information from this article is this graph. The top line that you see, because it's probably hard to see in the back room, are those with major opioids that they were using and dual diagnosis. And the dotted line is minor opioids with dual diagnosis, and the lines that you can't even really see that are way down below are major and minor, and they intersect without dual diagnosis. If your provider has dual diagnosis, they are at great risk to relapse. So very important piece of information for you. So what are the outcomes? We could save a career here. Wouldn't that be fulfilling to you to save a career? We can save a life, save a patient's life. We absolutely can. We can save the provider's life. 16.8% of people, physicians, who are referred for treatment didn't think about suicide. They attempted suicide. 16.8%. That's huge. That's a huge number. And we have to be really, really cognizant that this is affecting other people. We could save someone's family from devastation because of this disease and this problem, because of our intervention. As leaders, if this is not one of our biggest priorities, then I challenge everyone in this room to tell me what is. We need to protect our providers and protect our patients. So thanks, everybody. I appreciate your time.